What do you want to make sure?
They're spontaneously breathing.
They can spontaneously breathe. You want to definitely make sure the underlying issue that causes them to go on the elevator
Right.
is solved, right? So the point I want to make with extubation, don't look at one thing like their breath sounds or they can spontaneously breathe. You look at the whole picture. Here's what you got to look at. You got to make sure they can spontaneously breathe. You got to make sure the underlying problem that caused them to go on a ventilator is resolved or almost being resolved. Okay. You want to make sure they're on minimal sedation, because they won't be able to breathe if they're full sedated, right? Minimal sedation. You want to make sure they're hemodynamically stable. Make sure they're not requiring high doses of blood pressure medication to keep their blood pressure, within the range. So hemodynamically stable, minimal sedation, breathe spontaneously, awake and alert if they are normally awake and alert. Make sure they got good muscle strength, and that goes back to the PFTs or bedside mechanics we're going to talk about next unit. Make sure they got muscles are strong enough to extubate or get the tube out. So you look at the total picture is what I'm trying to tell you. Look at their labs, their white blood cell count. If they had an infection, that white cell count may be elevated. Make sure the white cell count's coming down and so forth. Now, as far as equipment, what equipment you need to extubate?
Everything we did.
Boom. You need all your intubation equipment, right? You need an oxygen source, an oxygen device. So what you gonna set them up on? What kind of oxygen device is the best? What are you gonna extubate them to? What do you think would be the best oxygen delivery device to set them up on?
A high flow device?
A large volume jet neb made with a mask.
Mm.
And the reason, because it is a high flow, meet their demand, plus you got that extra humidity for the airway post extubation.
Mm-hmm.
Now, as I told you in class, you're probably going to see them extubated in nasal cannulas mostly.
Mm.
But large volume jet neb would be ideal textbook way to extubate them. Okay? So you need to make sure that's up and running, ready to go, set up. Make sure your suction's still good, no leaks. So you got your oxygen, you got your suction, you got your intubation equipment in case you need to re-intubate. You check their breathing mechanics. What other tests do we have to check to make sure it's safe to extubate?
The cuff leak?
Yeah, the leak test. The leak test. And what's that checking for?
If the airway is swollen?
Yes. So what I want to do is take my 10cc syringe. It almost like the MOV, but I don't want you to call it MOV. This is called the cuff leak test. Cuff leak test. While they're on a ventilator getting positive pressure, you want to take your cuff, pull air out, and if you hear a leak, is that good or bad?
That's good.
If I pull air out and don't hear nothing, that's not good. So what do we need to do if we suspect a leak?
Leave it in.
Anti-inflammatory, exactly. You give the two anti-inflammatories you need to be able to tell me is Solumedrol and Decadron. Okay, Solumedrol and Decadron. Racemic wouldn't be indicated if they had an airway in place.
Right.
You don't give racemic till the airway's out
Mm-hmm.
and they have stridor. Okay, so steroids. So I'd wait 24 hours, come back and do the leak test again. Then if I heard a leak, that's a good thing. I can go ahead and proceed with extubation. Okay? So we want our patient in an upright position. Remember, intubation supine, extubation, higher up the better, actually. So I got my O2 set up. We've done a cuff leak test. I got suction ready to go, oxygen ready to go. I got my intubation equipment on standby. I got my patient on the monitor, looking at heart rate, SATs, respiratory rate. I got a chuck maybe to catch any sputum, lay on top of their chest. I'm ready to go. I got my racemic on standby in case they do have stridor when I take the tube out. So what I want to do is, I want those little tabs that I showed you. I see my little tabs. I can pull those. Get my other tab. Ooh, I see that one too. That's why you tab it, because it's hard to see any other way. Ventilator still breathing for them. Then somebody's going to be holding that. You need never extubate by yourself. And I'll take excess tape off gently, not quickly. All right. So I got my tape ready to go. off the patient, patient's still being ventilated. Next thing I want to do is get my cuff, syringe ready. Not deflate yet, but I'm gonna get it ready. So I got everything ready, talking to my patient, telling him what's going on, him or her. Patient upright. Now it's time at this point I probably disconnected from the ventilator. So disconnect from the ventilator, get somebody to turn that off for me. Mr. Jones, what I'm gonna do, I'm gonna take this tube out. When I tell you to, I want you to take a deep breath in. When they breathe in, the cords open up, and it's better time to take the tube out. But never take a tube out. You always, the last thing you want to do before you remove the tube is deflate the cuff. So I'm gonna deflate the cuff. All right, Mr. Jones, take a deep breath, and he's gonna take a deep breath. And the reason it's hard to get out now is because it's so dry, it's a mannequin, but it will come right out, believe me. Once you get the tube out, put it on the chuck. If you don't want to mess up your gown, I want to get my suction, my yonker, clean out any oral secretions. I want to apply the supplemental oxygen, large volume jet neb, and then I want to assess thoroughly. I want to do another 5-point auscultation, but we don't have to listen to the stomach this time. We would listen here for stridor, here, here, laterally, here, and here. So you don't have to listen to the stomach on extubation, just on intubation. So if they had a stridor at this point, I would give racemic epinephrine. Okay? If they didn't, you don't have to. Okay? But I would assess breath sounds, vital signs, see if they can speak, assess their phonation or speech, put on the oxygen, look at their vital signs, look at their SATs, make sure they're oxygenating adequately. 30 minutes later, I might want to get a repeat of arterial blood gas to assess ventilation and oxygenation, acid base, and encourage that patient to cough and deep breathe. One of the most important things they can do after extubation is cough and deep breathe. You might want to give them an incentive spirometer to do that. That all make sense? So that is extubation.